Welcome everyone to RTI International's COVID-19 webinar series. We're so glad you could take the time to join us today. I'm Dr. Pia MacDonald, an infectious disease epidemiologist here at RTI. I'll be kicking off the session today on vaccines and introducing our speakers. First, I'd like to tell you a little bit about the webinar series and the research we'll be sharing. We have conducted 3 previous webinars, each on Wednesday in the month of May, on different topics related to COVID-19. The data come from 2 RTI-funded national surveys of the American public. Last week's topic was perceived threats of COVID-19. We anticipate that the presentation will be 25 minutes and we'll spend 10 minutes at the end of the presentation on questions. Today, we will share findings related to the following questions. Are those most at risk willing to get the vaccine? What does willingness to get the vaccine look like in the rest of the population? How might current vaccine perceptions play a role in vaccine acceptance? We're fortunate to have an interdisciplinary team across RTI working on a range of COVID-19 issues, including the work you'll hear about today. I'd like to acknowledge the full team working on the survey. Representing that team today are 2 presenters, Dr. Brian Southwell and Dr. Bridget Kelly. Dr. Linda Squires will serve as the moderator for the question and answer portion of the webinar. Dr. Brian Southwell is the Senior Director at RTI. In addition, Dr. Southwell is an adjunct professor at Duke University and a graduate faculty member at the University of North Carolina at Chapel Hill. He has written numerous articles and books and hosts a public radio show, The Measure of Everyday Life. Dr. Bridget Kelly is Senior Health Communication Research Scientist. She has 19 years of experience in public health and communications research. Her research has focused on prescription drug risk perceptions and communication during infectious disease outbreaks such as Zika, Ebola, and H1N1 influenza. Moreover, she has published studies on message framing for vaccination of human papillomavirus and avian influenza. Dr. Linda Squires is Senior Health Communication Scientist and has worked in public health for 30 years. Her research focuses on conducting rapid assessments to gauge how the American public responds to high-profile public health issues. She also plans, implements, and evaluates large public health campaigns and led a project funded by CDC to develop its Clear Communication Index. If you have questions for one of our speakers, please submit your questions in the Q&A on Zoom. If you have a technical question about using Zoom, you can use the chat feature and Patrick will be available to help. After each of the webinars, we will email you the slide presentation. I'll now turn it over to Dr. Southwell to tell us about today's presentation.
Thank you, Pia. We really appreciate the opportunity during this last of our 4 webinars to look ahead into the future. In late April, Dr. Anthony Fauci voiced a hope that we'll eventually have a vaccine for COVID-19. We've already seen remarkable efforts to develop 1 or more vaccines. So we know that many people in our country are looking ahead to the possibility of a vaccination as a remedy for our pandemic. Now, in recent weeks, we've seen an announcement from the White House about efforts to encourage vaccine development. And we've also seen questions raised about how we can best ensure access to such vaccines and the acceptance of those vaccines. Now, we're clearly at a moment of great anticipation of future important programs in this arena. Now, in light of all that, a key research question is whether people will get the vaccines when they're available. Now, we can't yet study public reaction to a specific COVID-19 vaccine because one has been approved. That means that vaccination behavior is currently hypothetical. Nonetheless, we know that people are able to report on their perception of possibilities. In fact, there's a robust literature on the notion of behavioral willingness or openness to hypothetical behavior. We can predict and explain this openness. It should be a helpful guide. Necessarily an identical of what will be the case a year from now. Nonetheless, knowing where we've been and where we are now will be an important part of understanding where we might go. Now, part of where we've been is an information landscape that has spotlighted controversies and over vaccination. We've seen considerable news coverage for years about vaccine debates, and we already have seen some coverage anticipating divides in the case of COVID-19. We have to consider that as part of our context, and yet we also need to look at empirical evidence. Now, many commentators have noted that some of the challenges that we're going to face and that we seem to be when it comes to public trust in science are going to be relevant for our consideration here. At RTI, in fact, we convened a meeting last on trust in science, and one of the points of focus was vaccination. Now, one of our important contributors to that discussion, and I apologize if I'm breaking up here a bit, one of our important contributors to that meeting was our own Dr. Bridget Kelly. She helps me run our Science in the Public Sphere program in RTI's Center for Communication Science, and I'm pleased to share this Zoom stage with her. Now, after our colleagues moved swiftly to put a national survey into the field, Bridget, Dr. Carla Ban, and the team have been able to look at the resulting data to answer questions about vaccine acceptance. Earlier this month, we released a preview of the analysis through the blog produced by the team at the Journal of Health Communication. It's a blog called JHC Impact. Some results are available there for citation. Today, we're going to unpack the results a bit further. As you'll hear in just a moment, we've begun to answer a series of questions about vaccine acceptance, as you can now see on the screen. And with that, I'll turn it over to Bridget to present our vaccine perception results.
Thank you, Brian. I'll start with just a little bit about our methods. So to collect these data, we used Ipsos Knowledge Panel, a probability-based internet panel designed to be representative of US households. Ipsos uses an address-based sampling approach to recruit and maintain the panel. RTI developed the survey instrument and conducted the analysis of the resulting data. We conducted 2 waves of data collection with different respondents, and these data allow us to look at changes in perceptions over time. But the results that we're going to report on today are just from the second wave of the survey, which was fielded in mid-April. The data from both waves were weighted to represent the US population, and we collected data from approximately 2,300 respondents in wave 2. On this slide, you can see the characteristics of our survey respondents. While this slide shows data for the second wave of the survey, the demographics from the first wave were similar. We also had representation for all regions of the country, and we oversampled individuals with Hispanic ethnicity in wave 2. We included 3 main measures of willingness on this survey, and you can see those here on this slide. Some of the analysis we used for those, we've coded those into dichotomous measures of agree versus disagree, but they did have the 4 categories there. And we see that on the next slide, when we present the overall results for these 3 measures, 75% are willing to vaccinate themselves, 73% their children, and 60% actually said they would volunteer for a vaccine trial. So we wanted to find out if people who are at the most risk of severe illness or death from COVID are among those most willing to get the vaccine. So here's the current list of risk factors from the CDC. And we had measured almost all of these on our survey. While our sample did not include people in nursing homes, we could look at BMI, age, and presence of underlying medical conditions like all of the ones that are listed on this slide in our sample. We did have sufficient numbers of individuals with each of these risk factors in our sample to be able to look at their willingness to vaccinate specifically. What we see is that while those over age 65 were more likely than younger individuals to be willing to vaccinate, those with higher BMI and those with underlying conditions were no more likely than those without to be willing to vaccinate. So not everyone at higher risk is more willing to vaccinate than their lower risk counterparts. And the asterisks that you see on this slide represent the age categories that were significantly different from the older age group of 85%. And you can see that that 85% for the over 65 is a bit higher. Our next research question was about what what factors predict willingness to vaccinate? So we looked at the associations with a number of demographics and some perceived threat and worry variables. I'm going to show you those results now. For the sake of efficiency, I'm just going to show you the numbers for willingness to vaccinate the self, but many of the same patterns hold for willingness to vaccinate a child, and where those differ, I will mention that as we talk through the slides. So here we see that we do have some difference by gender, and this is a significant difference. We do not see this difference for willingness to vaccinate the child, but this makes sense because people may have seen a lot of the media coverage suggesting that men may be at more significant risk of hospitalization or even death from the coronavirus, and that could have something to do with that result there. In addition, education is a significant predictor of willingness to vaccinate. And here we have all the categories being less willing to vaccinate than those with a bachelor's degree or higher. For vaccinating the child, we did also see a significant result with those with high school being less willing to vaccinate than those with higher levels of education. There are some interesting results for race and ethnicity. We see here that we do have a significant difference for race, with Black non-Hispanics reporting a lower willingness to vaccinate than those in the white category. And we also see that those who identify themselves as Hispanic showed more willingness than those who were not Hispanic. This is not consistent with what we see typically for other adult vaccines, but we do see the same patterns for willingness to vaccinate the child for Hispanic versus non-Hispanic. And this is also consistent with some of the other findings in this survey that have been presented previously about face coverings and perceived threat. Some of those were reported on the previous 2 webinars. If you were not able to attend those webinars but are interested in seeing those results, please feel free to reach out to our team, and we're happy to share that with you. And so those suggest some demographic differences that are definitely worth further exploration. If we move on to the next slide, you can see that health insurance is perhaps the most dramatic difference that we see in all of our data, where those who have no insurance, only 47% of them were willing to get the vaccine compared to other categories. That is quite a significant difference. And we see a similar pattern with income. I don't have an income slide for you today because it is very similar, but we do see that as income increases, so does willingness. And so clearly cost is an important factor here. And the same pattern holds for willingness to vaccinate the child as well. In addition to the demographics, we wondered how risk and other perceptions might impact willingness. Some of you attended last week's webinar in which my colleague, Dr. Jessica DeFrank, presented extensively on our data related to perceived threat. This uses the same measure to determine how perceived level of threat influences willingness to vaccinate. So the measure was about what level of threat do you think coronavirus poses to you or your family in this case. And as Dr. DeFrank clearly explained last week, this differs from perceived risk because it also factors in the severity of the threat. So it's including both susceptibility and severity in that construct. And in other words, perceived threat is a measure of how bad is it and will I be likely to get it? And that's typically how we conceptualize it. And what's interesting here is that those with higher levels of threat were most willing to vaccinate, but those who answered don't know had the lowest willingness, even significantly lower than those who perceive the threat to themselves and their loved ones as low. So that to us seems like an opportunity for increasing awareness. For willingness to vaccinate the child, we see only that the highest level of threat to the self or family is significantly different from low threat in terms of willingness to vaccinate. And the last predictor we explored was worry. So worry is our other key measure in the risk category here. And this is more about continuous thinking or rumination about an impending negative event. This is how Dr. DeFrank defined it last week on the perceived threat webinar. It's more of an emotional construct than threat. And so our specific measure here was, I am worried about getting the coronavirus. And we find that those who are more worried are also more willing to get the vaccine. This is in line with prior research on predictors of vaccination for other diseases. For willingness to vaccinate the child, worry is also a significant predictor. Our last research question was about how perceptions of vaccines in general might impact COVID vaccine acceptance. So Brian showed those headlines about vaccine hesitancy and the anti-vaccine sentiment. So we had an index of 8 items about attitudes toward past childhood vaccine behavior. And some of these included items like, overall, do you think the benefits of childhood vaccination for measles, mumps, and rubella outweigh the risks? How often do you think vaccines have dangerous side effects? How much do you agree with the statement that vaccines protect children from serious diseases, and so on? And what we see here is that for those with positive attitudes toward childhood vaccines in general, most are willing to get vaccinated, 82%. But for those with negative attitudes toward childhood vaccines in general, it's about 50-50. So half are willing to get vaccinated for COVID and half are not. And that is a higher willingness than we might have anticipated among those who have generally negative perceptions about vaccines. So it deserves further exploration. But that other 50%, the 50% who are not willing to get vaccinated, is obviously an important group for public health efforts and initiatives to look to figure out what might be helpful in trying to persuade them otherwise. In addition to these measures, we had a measure of recent flu vaccination, and that turned out to be a very strong predictor of who would be willing to vaccinate for COVID. So that asked people, have you had a vaccine in the last year? And those who had had the vaccine in the last year were significantly more likely to be willing to vaccinate for COVID. So we know that all of us public health and health communication people are interested in vaccine acceptance and thinking about vaccine planning, but we wanted to know how much is this on the minds of the American people. So to put all of these findings in context, we looked at the open-ended data that we had included on the survey to see how important vaccines were among other COVID-related topics. My colleague Molly Lynch and her team coded 748 open-ended responses to the question, what is your single most urgent question about coronavirus? And here you can see that vaccines were the second most frequently mentioned topic. So this was in April, before some of the recent news stories. So it would be interesting to see what this looks like now, or even as we get closer to fall, if that percentage is even higher. And we also see here that the percentage who answered that vaccines for their most urgent question was actually a little bit higher in those who answered the survey in Spanish versus those who answered the survey in English. So what are the key takeaways here? I think there are a few important ones. Overall, willingness was higher than we've seen for past diseases, and that is encouraging and also likely probably partly due to the perceived threat from this illness. Obviously, there are some demographic differences that warrant further exploration, both to determine what's driving these differences in willingness and also to help develop interventions or messages that address the specific beliefs and barriers that are most relevant to those different audiences with culturally appropriate messages, and to ensure that we're using the right channels and the right messengers to reach those specific audiences. You'll recall that we saw that those who said they did not know about the threat level were even less willing to vaccinate than those who said the threat was low. This suggests to us that for those with unknown perceptions about the threat, really increasing that awareness may have an impact on their willingness to vaccinate. And message testing would obviously be a key piece of that piece. The past vaccines data suggests there is some work to be done to further explore determinants of those negative attitudes, and also to help identify strategies for reducing hesitancy and increasing acceptance in the more skeptical. So research to explore what is driving those negative beliefs. We see from the insurance and income data that cost is an important factor here. So as policy efforts address cost, and we know that there are some efforts already underway in Congress to make sure that cost will be addressed as a barrier for vaccination, it will also be important that accompanying messages get out there so that people are aware of how they can obtain the vaccine at low or no cost, or even aware that that's even a possibility. And I wanted to show you the World Health Organization's model for vaccine acceptance, because I think this is a good visual depiction of the complexity of vaccine acceptance and the importance of dealing both with the beliefs and the perceived risk and worry type of concerns, but also dealing with the structural factors that play into vaccine acceptance. So dealing with the problem at all levels. And then there is one last note that we wanted to end on. We see from the flu vaccination data that there is room to improve the number of people who are vaccinating for flu. So this is the percentage who reported having received a vaccine within the last year. And you can see that it's only about 55%. So that is, leaves some room for work there on improving that number. As White House task force leaders Deborah Birx and other officials have mentioned, a second wave of COVID in the fall accompanied by a bad flu season would put an even more significant strain on the healthcare system than we have seen this spring. So it will be more important than ever before that acceptance of the flu vaccine is high. And so we see this as a potential opportunity to maybe reframe the flu vaccination messages. If we want to go to the next slide, we can see, there are some reasons why flu vaccine acceptance has been low in the past. But maybe if we think about reframing those messages and using some of the types of altruism, messages about doing your part or helping to reduce the strain on the healthcare system, those messages that have been working to keep people home and social distancing, that could potentially have an impact on flu vaccination efforts as people begin to think of the flu vaccine as something they can do to do their part, or as maybe having a bigger impact than just on their own health. Message testing will be important now, and now is the time to do the formative work that can help with design and message selection. So I'm going to stop here and turn it over to Linda, who is going to lead us through the question period.
Hi, everyone. Before we start our question and answer period, we wanted to tell you a little bit about our Center for Communication Science. RTI Center for Communication Science comprises over 50 multidisciplinary experts in social marketing, behavior change, strategic communication, user-centered design, digital product development, message and materials testing, and campaign evaluation. RTI Center for Communication Science has successfully executed rapid response research and media campaigns for the 2016 Zika outbreak and the 2014 Ebola outbreak. We supported the CDC Foundation's Daytona Zika campaign in Puerto Rico and conducted research to understand travelers' comprehension of risk messages during the 2014 Ebola outbreak. So I just wanted to share that with you because we're definitely ready and equipped to support your communication science needs. And also up on the screen now, you'll see Bridget and Brian's contact information. So I know I've been watching some of the questions and answers coming in, and that, there are some questions that are really very specific to some analyses that we've conducted. Some of those we may just, email you the responses versus spending time in the broader Q&A. They're pretty specific questions to our analyses. But I'm going to go ahead and kick us off. We're going to spend about 10 to 15 minutes on questions and answers that have come through the Q&A portal. Thank you so much for submitting them. It's really helpful. And I'm going to read some questions and let our presenters respond. So the first one that I want to share is, Brian, I'm going to ask you to respond to this one. Why are you doing this analysis now when there is not a vaccine available?
Yeah, great. That's a great question. And it's, I touched on this a bit earlier, but I heard that I think some of my audio, there were some problems with that potentially. So it's a good chance to revisit what's a really important point. At our in the future. That's time to consider communication planning. And so, work like ours gives us an important baseline, and a place to start. And we know that people's openness today is predictive of the future. In fact, Bridget, if you want, can point to some empirical data from the survey that's suggestive in this regard.
Sorry, Brian, about the willingness to.
About past, past behavior, vaccination behavior, actually, where we are now, being predictive of the future, even though we're
Right,
in a
yeah.
hypothetical
So we did see
circumstance.
that in the multivariate model, when we include demographics and other predictors of willingness to vaccinate, past behavior, past vaccination within the last year for flu vaccine is actually one of the strongest predictors amongst all of those different variables.
Great, thank you so much. Bridget, I'm going to ask this one of you. Will people's perceptions matter if the vaccine ends up being mandatory in schools and nursing homes, et cetera?
Yeah, that's a great question. And I think there is just a lot of uncertainty now about what that policy is likely to look like going forward as schools think about opening and more states are opening more broadly. We don't yet know what COVID vaccine policy will look like. While it's possible there will be some locations that choose to make vaccine mandatory for some individuals, maybe for healthcare workers or for children going to schools, it's also likely to vary quite widely from state to state or even more locally. And so an important next step could really be exploring people's perceptions of mandatory vaccine policies or recommendations for vaccination, just to look at some of the different options that are being put out there on the table for localities to consider, and then to examine those perceptions on those local levels and and see how many folks are in favor of them.
Thank you so much. Okay, so Bridget, I'm going to ask you another. I think Brian's going to call back in on his phone. I know he's had some challenges there with the audio and video together. Your data seems to be one more example of health disparities in the US. How should research address this?
Yeah, that's a great question. And we have thought about this a lot as we've been looking at some of the numbers. We do see some demographic and insurance differences in willingness to vaccinate that point to the need for public health work. Some of these, like cost, might be best addressed with policy as opposed to a communication campaign, for example. But others, such as lower willingness to vaccinate amongst specific demographic groups, may call for other types of research, qualitative studies, focus groups, or interviews that can really help to identify what are the barriers, what are the beliefs that are driving the hesitancy, and how can public health efforts and media campaigns focus on those specific beliefs and barriers that are causing the disparities that we see. By doing this research now, we can have insight on which subgroups may be impacted by vaccine uptake related disparities and how they could be in part mitigated by communication efforts or other public health research.
Thanks. Thank you so much. Okay, so I'm going to turn to some of our questions that have just recently come in. And some of these you may not be able to answer off the top. And like I said, we will certainly respond by email to those who have posed these. Sorry, what were the effects of education controlled for when examining racial differences in willingness to get a vaccine?
Yeah, great question. So we do have multivariate models where we've looked at both race and education and all the other predictors in those models. And what we see is that both are significant even when controlling for the other. That is true for the Hispanic origin variable as well. They all remain significant in those models. We have a lot of strong demographic predictors of willingness to vaccinate. And the same is true for willingness to vaccinate the child as well. I think income is the only one that drops out as becomes not significant in the multivariate model for willingness to vaccinate the child.
Great. We've had several questions asking if we've compared the data in this presentation with public attitudes towards vaccines in general. So I know you can speak to this a bit because that's actually some of the variables that we did have were about attitudes towards vaccination in general.
Yeah, so we did have the one slide. It is limited because it is specific to attitudes toward childhood vaccination. So measles, mumps, rubella, regular immunizations for children. But it is an index of 8 different variables, which I've read some of those earlier, but they're things like your perceptions of whether the risks outweigh the benefits or vice versa. You know, do they protect children from serious illnesses, for example? And we did see that there was a big difference between those who had positive attitudes versus negative attitudes toward child vaccination, and whether they're willing to vaccinate a child. So it was about 50-50 for those with negative perceptions, and it was 82% willing, those with positive perceptions. We didn't look at that we did, but we didn't present it. Willingness to vaccinate the self, and there is a significant difference, but it seems a little bit less relevant because the measure of past attitudes was specific to childhood vaccination.
Mm-hmm. Yep. And you just answered one of our other questions, so thanks for doing that. Okay, so do you know if African Americans are less willing than other groups to get flu or other vaccines, or is this pattern specific to COVID-19?
Yeah, it's a great question. And we do see similar findings for other types of vaccination. I believe with elderly for pneumococcal vaccine, for flu vaccines, and I don't know specifically for HPV there with the adolescents if there is that same difference, but we've seen similar types of patterns in previous and in current vaccine, adult vaccine.
Okay, so Brian, I'm gonna toss this one to you. The anti-vaccine movement has been promoting misinformation on social media. How big a role is that likely to play?
Yeah, it's certainly a interesting and important observation. We share an information environment that includes a fair amount of misinformation. What we know, though, generally, and this is really important to keep in mind, is that I think people are trying to keep themselves and their families healthy. That's something that we all share in common. And we're learning a lot about how to provide good and credible information to people. And we know it's going to take concerted and planned efforts to make sure that people have good information. So I think one way to think about the environment and the opportunity is to frame that optimistically, to think about the opportunities we have to reach people who are trying to keep themselves healthy, to keep their families healthy. And there are ways to do that, but it's not going to happen by accident. It's going to be important for us to think about how to reach people, what information is that they need, and to go about the effort to do that in a concerted way, with communication campaigns and other communication efforts.
Great, and this question really builds on what you were just talking about, Brian, and it's, will you be doing formative research on anti-vaxxers and their willingness to get COVID-19 vaccine and to assess what factors may influence their decision?
I think formative research going forward is going to have to include all Americans. Formative research is going to have to look at how it is that we're all thinking about and understanding, these opportunities that are before us. And I think that's something that, we've done, with this, survey. We included a wide, swath of Americans' perceptions here, and we're going to have to continue to be inclusive, there. We know that people have different backgrounds and different perspectives, and it's going to be important to engage, a wide range of folks as we think about the best ways to reach people. So it's a good point to raise.
Okay, so we had a question really about our plans to actually continue our survey efforts, and I'm happy to take that question. So we really would like to. This, as Bridget and Brian mentioned at the beginning of the presentation, is actually our second survey wave. We did the first one back at the very end of February. And early first few days of March, when the first death due to COVID in the United States happened. And then this second wave was done mid-April, right in the middle of the lockdown. It's really important that we continue to take a look at the public's knowledge, attitudes, beliefs, and behaviors around vaccination and many of the other topics that we have presented in this webinar series, such as the using cloth face coverings and social distancing, especially as the states are opening up, and being able to get the pulse of what those beliefs and behaviors are, and really trying to understand what messages in terms of prevention are getting through and not getting through. We really would like to continue this work. RTI has funded these 2 survey waves ourselves with our internal funds. We are a nonprofit research organization, but we really are looking for external partners at this point to help fund future waves of the survey and continue this work going forward. So if you are one of those organizations who are interested in partnering, please feel free to reach out to Brian or Bridget or me, and we would be happy to really talk through what's involved in that kind of partnering and effort. Certainly as a partner, you would get to craft lots of the questions that could go on a future wave. So there's a huge opportunity there. You know, that's right now, that's kind of where we are, is, you know, we're really hopefully going to find some external funding to allow us to continue. But we've put out, you know, a lot of information in less than a month, you know, based on some data collection mid-April, and then also from back in February as well. All right, so then another question is, actually I'm going to turn to this one that came in a little bit earlier. Is, do you think, and Bridget, actually I asked that, sorry, what, Brian, what about the fact that your measure is about willingness to get a hypothetical vaccination? You may have already answered this, but I'll pose it again.
Well, you know, but so it's worth raising here that we're going to need an array of you know, measures as we sort of understand the subtleties and nuances of all these different perceptions. So we're able to take a snapshot now of openness, you know, for the future. You know, I think as we move forward, our question wording likely will eventually include a very specific reference to specific vaccines or vaccine that gets developed, and that's going to be important. So we're going to have to continue to do all this in a rigorous way to understand how we've measured things in the past, and to continue to you know, develop questions that reflect the new moments that are likely in our future here together. So that's why we're starting now to work on that.
And we had a question earlier on. We're going to navigate back to this particular question. And the question is, would the speaker review the insurance slide again? What does other and don't know mean? Bridget?
Okay, so those were categories that were chosen by the respondent who was either unsure of what type of insurance they had, or has some other type of insurance other than what we had listed in these categories. So this was a closed-ended item, and they selected the answer that best fit the type of insurance they have.
Thanks.
Does that, hope that answered the question.
Yeah. All right, and then another question's come in that says, can RTI support COVID-19 research in Africa? Yes, we can. And we very well may be doing that already. So yes, we can do international surveys and have several options for doing that. So again, feel free to reach out to any one of us listed here. All right, I'm going to do one more question, and then I think we will wrap it up. Are additional surveys in the works to address the racial disparity of the impact of COVID-19 and vaccination? Bridget or Brian?
So I think, as Linda mentioned, we don't have another survey in the works right now. We would love to do that work. And obviously, there are some very important differences to look at further here. And both with survey work, but also formative research, qualitative research. And, you know, I think there are a lot of different ways that you could try to explore that in more depth, and it will be important to do that work before a vaccination is available.
Thanks. All right, so if I did not pose, we've gotten so many questions coming in, and thank you all so much for sending them in. If I did not get a chance to pose them, then you know, certainly feel free to email, and we can respond individually by email. I wanted just to end today with the importance of doing testing of public health messages. That's really critical, even not just on vaccine, but as we promote many of the other COVID prevention efforts. So that's something that's really needed, something else we can support you with. We've just put a slide up that shares really RTI's other capabilities. We've talked earlier about our Center for Communication Science, and we have capabilities there from formative research to summative. We develop communication messages, materials, digital products, campaigns. We develop, implement, and evaluate all of those. And then this slide before you really shares that we've got a deep bench that goes beyond just our communication expertise. We have a division of public health, and then across RTI, we have cross-functional experts in epidemiology, survey research, innovation experts. So we can you know, reach out, and please feel free to reach out. And if you want to discuss potential opportunities and partnering, we'd be really delighted to speak with you. So we'd also, as you exit the presentation, there is a short little survey. I promise it's short, just a couple questions for us to get feedback from you about today's webinar, about our webinar series, and also gives you an opportunity that if you would like one of us to contact you, you can put your contact information in there. We would really love to partner for this research and other COVID research, so please feel free to let us know of your interests, and we will definitely follow up with you. Brian, Bridget, or Pia, sorry, any final words from any of you?
Well, the main thing is just to thank people for taking time. Everybody's challenged these days, and there's a lot of other things going on. So for you to focus 45 minutes with us, we really appreciate that, and we look forward to this being part of a longer term conversation. So thanks to all of you for joining us today.